Hi, very good morning, everyone. Uh, Welcome to our weekly CMAAO Live International meeting. Today, we are on 14th of March, and we have a very important topic, advances in asthma and allergy. I believe we have been seeing a lot of issues in this world today. Asthma and allergies are something which a lot of people in this world would be facing, a very important topic. We have Dr. Vijay Warad. He will be talking about advances in asthma and allergy. He's an MD consultant allergist, pediatrician, pulmonologist, clinical immunologist, consultant at Sai Allergy Asthma Eye Hospital, Imandar Multispeciality Hospital in Pune Allergy Center. Sir, over to you.
Thanks, Saurabhji, for the introduction. Thanks to Simao for giving me the opportunity to discuss my 25 years of practical experience as well as research in the asthma allergies. And thanks to all the seniors and my colleagues which have been joining here and to listen me and to interact with me. And I will also learn from them a lot about these things because it should be useful to the community. Ultimately, I will also learn from them a lot about these things because it should be useful to the community. Ultimately, as a doctors, we always want to give a benefit to the community. And practically, as you rightly said, the changing scenario among the diseases, specifically in India, like previously used to have a lot of infections and all, and now it is changing, and a lot of cases of non-communicable diseases. Amongst that, the allergies have been a very important part in managing these cases, and the presentations are changing also. Previously, like hardly seasonal allergies used to be there more. Then it has changed now to the perennial throughout the year. The cases are increasing, and even 27 years back, hardly one patient of anaphylaxis is to be there sometime in a 6 months or something. Now we are having at least one patient in my OPDs with a severe anaphylaxis or refractory asthmas from children to the adults requiring biologics treatments, and that awareness is lacking in India. Still, the practitioners like pediatricians, ENT, chest physicians, and all, they are just symptomatically managing, and the environmental control for the patient has not been educated. That's why people are just suffering and they're just turning to the alternative therapies like Ayurveda, homeopathic for all these problems when already proper after the MBBS MD, there are so many advances in allergens management, desensitization, the targeted therapies like probiotics, biologics, additional therapies, then supportive therapies like whatever the environmental control to the patients should be made aware. So as for my topic today, like what are the advances in managing these asthma allergies? So but just before that, I will like to share with everyone like quick reminder like because in India there is a misconceptions amongst the patients and the service providers that whenever the child or any adult has a repeated cough, cold, or throat infections or respiratory problems or skin problems or something, they are labeled as that there is a lower immunity and we increase the immunity and cure the disease. So these misconceptions are causing a lot of problems. And so whenever the patients of asthma allergies come to us, they will always ask, is there any 100% cure? So the simple problem is that. So they don't understand it is not a low immunity, it is a hypersensitive diseases. And as like how we manage diabetes, we bring the sugar to 80 to 120 to have a normal life. The same way here, we can have a hypersensitivity to the normal sensitivity practically, and the patient can have a good quality of life to prevent the complications of oral and parenteral steroids so much used in India because 2020, when for the Indian Academy of Pediatrics, I was given the topic like what are the use, abuse, and overuse of steroids in India. I was shocked that 90% of the patients are given a repeated steroids in some or the other forms to the patients and having a complications. So even now it has been found that neonates are also suffering with severe allergies. So it's not only the children and adults or adolescents, even the neonates. So if the parents have a significant allergies, the child even at a very small or early age can have a complications. So as a practitioners, we should educate to the patients that it is not just symptomatic management with allopathy, homeopathy, Ayurveda, or whatever the alternative therapies or something. But our long-term approach should be to prevent the severe allergies, severe asthma, chronic respiratory diseases. So the proper allergy management, like how we manage a blood pressure and diabetes, that awareness should be there. So while managing with a proper advances like a standardized allergy test and to control the inflammation for a long-term benefit, so that insights to the people and the precision medicine management should be made aware. So early stage, what happens with the sensitization stage? Most of the patients this have a symptomatic relief with simple antihistaminics or nasal steroids or inhaler or nebulizer. But once the patient goes to the effector phase, where not only the histamine but the other inflammatory mediators are released, then the patient does not show the same response to the same medications. Then he gets confused and then he goes to so many multiple therapies, multiple pathies management. So even like World Allergy Organization is doing so much awareness about this and how we can prevent these severe atopic dermatitis, uh, food allergies uh, amongst the community. So not only worldwide, even India now we are seeing a lot of food allergies. Like 6 to 7 times the admissions into the children have increased because of the food allergies. Even I have a 2.5 year child. When she was playing into the kitchen with the smell of the milk, she had an anaphylaxis. She was rushed to the hospital. So such type of cases are increasing in India also. So if the parents are treated properly and early recognition of the hidden signs of allergy like dark circles, wrinkles under the eyes, long eyelashes, or rubbing of the nose, eyes, or ears, cervical lymphadenopathy, open mouth breathing, or upper caries teeth, halitosis, white coating of tongue, posterior pharyngeal hyperplasia. These simple hidden signs can be picked up into the children, and we can prevent these severe skin allergies or so many connection of allergy, autoimmune allergy, food problems, gut inflammation. And there are so many studies now, even the Th2 inflammation to the throat, then such type of presentations are there. Even the environmental allergens, they are swallowed also. Then the gut mast cell and eosinophilic sensitivity can happen. And among these many patients with asthma, respiratory allergies or something, many of them have a gut problems also, gut inflammation. So there is a significant connection of this gut microbiome with the skin, hair, and seborrheic dermatitis to even urticaria to eczemas to psoriasis, so many things. So the while managing these asthma allergy patients, it's just not only just inhalers, nasal steroids, or just allergy testing and all. Beyond that, even we should manage the proper gut so that these connections of gut lung, gut brain axis, and gut skin and all that also can be controlled. So integrated and holistic approach is required with some supplements also, antioxidant medications, and managing the gut dysbiosis also. So it's already in India, every third person is suffering with some of the other allergies. Children, number one chronic disease is childhood asthma, and these are missed by many of the patients. So, like for example, practically, since so many years, I'm saying to my patients, stop the brooming, use the vacuum cleaner, but they're not ready. So they don't see these allergens easily, like dust mites. They are in crores. Like daily, we shed around 1.5 gram of skin. On 1 gram of skin, more than 10 lakh dust mites can survive. Even last 25 years in Maharashtra, in Pune, we are trying to have pollens depending on the area wise so that the cost of therapy can come down. We can have a very selective test for the specific pollens because there is a lot of diversity in India. There is a lot of regional variations. Nowadays, previously we used to have our own plants, but now a lot of other trees from the other countries have been in Indian scenario on the roadsides and all. So like prosopsis and all, significant allergy. 130 kilometers they can travel through the air, and so they cause a problem. So we have to identify that, and whatever the people talk about the cancer and all, but allergy, asthma, COPD overlap syndrome has been very well documented. The chronic obstructive pulmonary diseases have increased. It is the second death causing disease in India. So it's one more important, which is underestimated, underdiagnosed, and overlooked in our scenario is a ocular allergies. So even the World Allergy Organization 2018 has said that 95% of the rhinitis have some or the other hidden signs of allergy and they are underdiagnosed. So that's why a lot of people are going into vernal keratoconjunctivitis. Because my spouse, Dr. Ushali, is in a ocular allergies, and we get a lot of 17, 18, 22 years old children with significant keratoconus requiring more than 27,000 INR lesser treatments, then early age cataract glaucoma because of the repeated eye steroids and all. So there is a significant connection. So most of the ophthalmologists, what they do is that they just symptomatically treat with the ocular symptoms, just put the eye drops, or but then repeated eye steroids causing a problem. But this nasolacrimal reflex and nasolacrimal duct connection, connecting these things and causing a significant symptoms. So these patients also, along with the eye steroids, the nasal management, then systemic effect of allergy. So the allergen management awareness should be brought so that the complications of the disease, as well as the, like, see, you can see this picture, even more than 320 millimeter of mercury pressure increases when the child rubs the eyes. You can see with the knuckles, around more than 4.5 kg pressure is built on the eyes. So that is also very important. Then angioedema, anaphylaxis. Like this was a 14-year-old girl. 6 years she was suffering severe depression, and nobody controlled her environmental things and allergens. This was from a very interior part of Maharashtra, where the child patient had a significant asthma, and he had a parthenium, like English plantain in USA and all. Then prosopsis, significant sensitivity, and he was just given a oral steroids and repeated admissions for that. This was a 19-year-old girl with a severe multiple food allergens. Paracetamol triggered anaphylaxis first time, and she was admitted. You can see the protruded jaw, then flaring of alinae, this dark line on the nose at the junction of the things. You can see the uh, wrinkling under the eyes, and the same patient, you can see the turbinates also, and the posterior pharyngeal hyperplasia. So nobody guided her during her childhood when she used to have a seasonal symptoms. Your underlying inflammation is continued. Your allergens should be managed. Like this was a 7-year-old child with a significant seasonal cold cough in the past. Now on repeated ocular steroids, cyclomium drops, tacrolimus suggested intraocular steroids. So the child was referred to us. He had a significant Still's ulcer. When we examined his underlying allergies, his IG was 110. We started on a omalizumab, which is a very good molecule as a targeted therapy. And within few months, within 4 months, his all the Still's ulcer regressed. His inflammation came down. His rubbing and all went down. He did not require intraocular steroids. And you can see like the dust mites and the grass pollen sensitivity was significant. Then amongst the asthmatics, even now children's also, we can do a simple oscillometry and external nitric oxide testings. It can be very useful. Again, in some of the patients of asthma, they can have exercise-induced asthma. Some of the patients can have food-induced exercise-triggered anaphylaxis. And I have 27 patients with such type of presentations, youngsters, adolescents, adults. So they were missed. So some of these exercise challenge tests, EFTs, can be done now. Still in Indian scenario, there was a study done in 2014 where it was found that hardly 8% of the patients these pulmonary function tests are done. So 92% of the patients are just symptomatically treated. So they can be monitored properly. The spirometry, exhaled nitric oxide, oscillometries can be done. And like before the starting of this webinar, as Dr. Monica and Sauravji were discussing, how the AI-based therapies, even the mobile can detect these things, peak expiratory flow meter, because when in the clinical trials we have used these electronic diaries and all for the patients. It is very useful. The patient can monitor their PFR daily, morning, evening, and they can do the spirometry also. They can analyze when the exacerbations can be there, so that they can increase the dose of inhaled corticosteroids and all. They can have a good quality of life. This was a 14-year-old growth retardation, barrel sepsis, curiosity thorax, cystic fibrosis cup, bronchoscopy, ball done, all possible treatments for them. But when the patient was referred to us, we did a testing and all. You can see the dust mites and mold sensitivity was significant. And after the, because these molds are into the school bathrooms also, the children they eat everything, the small particles they fall into the deep pockets. We did a study in Pune, 65 asthmatic children. We found the brushings from the deep pockets of the schools, classes, or the molds on the bathroom walls and all. They are exposed. So this child started taking some precautions with the mask and desensitizing against the dust mites, and he had a very good recovery within few months. This was again 12-year patient from a rural area. They are from a farmer's child, and he was treated with so many things, repeated nebulizations, inhalers, but he was not getting a control. You can see the protruded jaw, the long eyelashes, the Denny Morgan fold, and the turbinate hypertrophy was there. He had a deviated nasal septum, and he had a significant multiple pollen sensitivities, because in Indian scenario, a lot of pesticides are used into the farming. So in the rural areas also, the pollen's potency has it. It was a basically posterior nasal dribbling, upper airway cough syndrome. When we manage the upper airway with the nasal douching, nasal steroids, some safer anti-inflammatory Montelukast with bilastine, and the patient had a very good recovery. He did not require much nebulizer and inhalers and all because it was a just upper airway cough. Then this was a patient referred from one of the corporate hospital with a 3 times admitted with severe bronchitis attacks within a period of 2.5 years of age. And you can see atopic dermatitis. Even most of the dermatologists have said that he has to take it up to 8 to 10 years. His IG was around 3,500. And when we did a testing, the dust mites and milk sensitivity was significant. We started desensitizing the dust mite with the sublingual immunodrops, and within 9 months, he had a very good recovery. And quality of life improved a lot. Now is much better. Then this was a 5-year-old child rushed to the corporate hospital after having a peanut butter and significant anaphylaxis. So he used to have sometime seasonal cough cold, inhaler was going on. He was treated with that. So the parent thought it is a peanut anaphylaxis. But when we tested with the component diagnosis, it was a dust mite sensitivity significant. So the combined effect of that, the child was playing in that day somewhere in the sofas and all, and along with that, the peanut butter were contaminated with so much dust mites. After the oral injection, he triggered that and he was rushed to the hospital. Even now, the I just analyzed some of the data. Even internationally, the PubMed also has said that whatever the repeated upper airway, like tonsil, adenoids, throat, and all, 60 to 80% of the patients can have a Th2 inflammation. And amongst that, around many of the patients, the hypersensitivity is very important, where these patients are told that their lower immunity is there, and that's why they are having this problem. But the primary, the Th2 inflammation is there, and the secondary infections like viral, bacterial, and all, they trigger the inflammation. Common symptoms like post-COVID, at least we are seeing a lot of cases of eczema, urticaria into the children, or tonsil, adenoids, snoring in the children has increased a lot, mouth breathing and all. They have a significant protruded jaw, upper cavity, sleep disturbances, then affecting the cognitive and behavioral disturbances also in these patients. So this to be managed properly so that the what will happen, there is no need of unnecessarily rushing to the surgeries, because once we interfere over here, the allergy will lead it to another part of the body. So my 25 years of experience, I have seen that rushing to the surgery is not helpful. There are some guidelines where really if it is obstructive sleep apnea, which is affecting the sleep and it is interfering with the sleep studies only, polysomnography, then only the surgery should be planned. Or rest of the patients with the Th2 inflammation management with some of the allergen testing like molds, dust mites, their precautions with the nasal steroids, nasal douching, some safer medicines like Montelukast and antihistaminic combinations, and some of the integrated like vitamin D, zinc supplementations and all, and some of the probiotics also nowadays. Some trials are happening, and we are giving some respiratory probiotics and some immunomodulators locally, and they are very useful. So it's a systemic disease, and asthma amongst 90% of the children with asthma, there is a primary allergy. Adults also, around 65% of the adults have a underlying allergens trigger, and they are not diagnosed and they are not being controlled on that. The environmental control is not educated. That's why if you see the chronic respiratory disease in Indian scenario, I think worldwide also it is some country third or fourth leading cause. India, it is a second death cause in disease. And while managing the inflammatory conditions, such asthma allergies also, the integrated approach for the microbial, dietary, exercise, then sunlight exposure, indoor and outdoor pollution. People talk about only outdoor pollutants, but the indoor pollution, like use of overuse of these perfumes and in traditionally so many uh, smoke happens in Indian scenario. Like there are chulas, the rural areas or slums. Then again firewoods, basically the burning of the firewood, and even the in front of the god so many scented artificial one like agarbattis and groups and all they are used in Indian scenario. And then the misery, like it is called the burning tobacco. Like a lot of in Indian scenario, a lot of people are using that in the specifically urban slums and rural areas. So that tobacco burn and then it is used on the teeth and all to clean it, to keep it over there. So these also again causing a problem. So then these are the other comorbidities which should be educated and that awareness to the community. So while treating the patients, the symptomatically, since ages, people are taking Ayurveda, homeopathic, traditional medications, then antihistaminics, then nasal steroids, inhalers. Still in India, the nasal steroids and inhaler are hardly used in 20 to 30% cases. 70% of the patients are worried about it that they feel it is a addictive and that addiction will be there lifelong and the patient has to take it. So they are scared about that. Still, there is a social stigma about this thing. Now, if you see, as for the today's topic, the monoclonal antibodies, the allergen testing, what are the exposure of the dust mites, pollens, insects, animal dander, molds. We can guide the patient about what type of simple precautions and we can reduce the overuse anti-allergics or steroids in these patients. Then there are specific mast cell stabilizers in the ocular allergies or even the local immunomodulators like tacrolimus or cycloimine and all can be used in the ocular allergies. Then the desensitization or the disease modifying therapies like immunotherapy, hardly 0.02% patients it is used in Indian scenario. So that awareness should be brought that we can prevent the complications. Like one 54-year-old had a from the rural area had a rhinosinusitis, blocked nose, used to have a repeated anti-allergies. We did a testing and he had a Parthenium cynodone. It's used commonly to offer to the Ganesha in Indian scenario. So a lot of people they use it in the early morning on Tuesdays or some festivals and all. So the patient had a sensitivity to that, and while he was taking so many oral steroids and all, but when we guided him about the same simple management, nowadays the glucoregulatory and uh, uh, like N-acetylcysteine acebrophylline. And then we started on a desensitization against the pollens. And he had a very good recovery within few months. So even the rural areas, these so many pesticides are used into the grasses and the farming. They cause a problem. So each and every country wise, we should analyze the prevalence. We should analyze not only the disease pattern, even the pollen pattern which changes. Some of the foods, some of the foods also extinct, and some of the trees are also cut, so some new trees are implanted, so some of the new allergens can be there. And as the child grows, he will have a single to multiple sensitivities. And once it reaches to that level, then they will have a severe asthma, allergy complications and all. So this awareness among the practitioners is also very important that symptomatic management is not important. Among that, a lot of are going into the complications. So these are the culprits where they are underdiagnosed and overlooked. So even the GINA now has accepted that the immunotherapy has been very well useful in immunoregulating these patients to treat the asthmatics also. So allergy testing in the early stage, once we suspect it, we can select some of the allergens. There is no need of going to all the panels of tests, and we can guide the patients about the specific precautions. So early detection is important than patient landing into the severity, and then all the things started. So then they get aware and they go to so many doctors and they change the pathways. So rather than that, in an early stage, these type of cases where we can identify the specific IG or the specific allergens, including the environmental foods, insects or molds and all, and we can guide them what type of precautions can be taken. And see, like how, like a wall, I always give an example. See, rather than changing just the paint or the uh, engineer or something, we find out the leakage as an architect, how their role is there. The same way, allergy specialist role is into this, and how we can manage these patients in a proper way. You can see like skin prick test around 60 to 90% of the children and 60% of the adults. It can have a very important role. Even 2017, the Indian College of Allergy, Asthma, Immunology guidelines also we have given importance to the awareness and all, and which tests to be done. So many advertises are done by the pathology labs in India, and the people are misguided. But actually, the standardized skin prick test for the environmental allergen is still best. In some of the patients with the insects and drug allergies, the intradermal testing can be done. Then blood test only in case where it is a significant food anaphylaxis or there when there is an insect anaphylaxis, then the component resolved diagnosis can be really useful. Otherwise, the specific skin prick test, but it is cost effective. The IG is not much useful. The serum specific IG, the cost is still per allergen around 700 to 900 rupees. while hardly the skin prick test is 100 INR. So why it is? Because there are studies done where it has been found that the standardized skin test, it picks up the mast cell bound IgE than the circulating IgE. So the clinical correlation is much better with the skin prick test. Only before the skin prick test, we have to stop the antihistaminics or chronic steroids for a longer period. So 6 to 7 days before that, antihistaminic should be stopped. And there is no age limit, but only thing is that above 6 months it is much preferred, and because the receptors are developed above 6 months. So positive test is up 3 millimeter, and even nowadays 1 millimeter lancets are available in Indian scenario. And those cases where there is a significant food allergy, against the food allergy there is a lot of misconceptions. But actual food allergy is hardly 2 to 5%. 95% patients have a food intolerance or cross reactivity, and most of the people feel that they have a food allergy. So when it is needed, then only the food allergy test should be done. Otherwise, we should educate to the patients that it is a cross-reactive or intolerance. Because if it is a food allergy, within 2 to 3 hours, the patient should have a response like severe pain in abdomen, puking, vomiting, or dizziness, like anaphylaxis. We will see in next few slides how those presentations can be there. So even in some of the patients, if there is a real food allergy, then we can have the cross-reactivity to the different type of pollens and fruits and all. We can guide the patients. Like suppose birch pollen, it is a cross reactive to the apple. Then grass pollens, they are cross reactive with some of the banana or avocado or something. Then dust mite cross reactive to with the tropomycin of prawns or fish, shellfish basically. So we can guide according to that. So even in India now, the pollen calendar is available. We can guide the patients about all these things. Still, definitely, as compared to the Western countries and all, Indian scenario, the allergy has not been that much given importance. But now, within last decade, a lot of awareness is increasing. We are conducting a lot of workshops in India, making awareness. So now even the microarray assay method like multiplex and singleplex are available in Indian scenario. We can identify the cross reactivities in advances, and we can guide the patient not to worry when there is a simple urticaria or angioedema. And if it is a real anaphylaxis, they can keep even adrenaline injections with them. They can identify like RH123 sensitivity if it is there, then the anaphylaxis chances are there. Now we are seeing a lot of seismic allergies in India because seismic seeds are used so many years in Indian scenario. On Sankrantri, there is a festival very well known. The kites are flied and all. So we never used to see the allergies. But now maybe because of the genetic change into the seismic seeds or the allergic tendency of the patients have increased. Post this festival, I am seeing a lot of cases of severe allergies of seismic seeds. Latex sensitivity is very common. There was a 13-year-old child who had been to dental treatment, and the dentist thought it is a xylocaine sensitivity. But when the patient had been to me, we did a componentizole diagnosis. After analyzing all the things, it was a latex sensitivity, and that's why he had a angioedema and like a severe lipedema and ocular. So then honeybee and fire ant wasp anaphylaxis cases are increasing only, and the shellfish and the shrimp allergies have also increased. So last 25 years we analyzed the things and we guided the people that actual food allergies are very less. Most common in Indian scenario also the dust mites, pollens and molds. Now pigeon feather allergies 40% in urban cities. A lot of pigeons are there. And feathers, there are 17 types of dust mites to the feather. So after the proper allergen testing, we can guide the patient what type of specific precautions can be taken. Suppose there is a dust mites, you can see like how the dust mite proof covers, then washing the bedding in hot water, dampness and humidity can be managed because the air conditioner use has increased because of the corporate offices and people are using during the summers and other things also. Even the car AC, a lot of pollens are sucked in. So if the patient has a sensitivity to that, then car pollution is much higher. There are funguses, there are dust mites into there. A simple vacuum cleaning after 8 to 10 days. Suppose pollen sensitivity is there before going to the school or offices, they can use a mask during that time. Then depending on the pet sensitivity, the pet should be kept away from the beds and sofas. Cockroaches and all, the pest control can be done very well. Funguses, if the molds are there, the 5% liquid ammonia can be used like 10 ml in 100 ml of water and they can spray on that. The spores can be reduced, the potency. So depending on the relative pharmacotherapies, like nasal steroids, oral montelukast and tezoprenadine or borbilastine combinations, inhaler therapies. Besides that, the specific allergy desensitization, vaccines or tolerance development, that awareness is lacking in Indian scenario. So even as I mentioned, hardly 0.02% patients know about this allergy immunotherapy, which has been 113 years in the world. But in Indian scenario, the awareness is lacking amongst the practitioners also. Even the practitioners don't know about the dust mites, pollens. They just talk about the food most of the time. Because when I get a prescriptions from the doctors, from the ENTs and all, they always guide about the just common dust, not dust mites and all. And they just write it like these avoid this milk, avoid these nuts and lentils and all. But never nobody talks about the environmental allergens. So what are these desensitization or allergy vaccines? These are the specific administration of gradually increasing the quantity of the allergens extracts, the purified one in a subcutaneous sublingual forms. They are from thousands to 500 to 400 to 100 to 150. So 1 has to 50 concentration, so that the tolerance of that patient develops to against those allergens. The specific IgG1, IgG4 antibodies are formed against the specific IgG. Even last year, first time in India, now very advanced, very purified form of uh, sublingual tablet is available, which is very good. In USA and all, that is called Acarizax, but in India it is called Sensimune, and which has been launched and which have very useful about 12 years of old. Even in Japan and all, about 6 years they have used the another version of rather than 12 SQ HDM. It is a 6 SQ HDM, and which has been very well useful. Only the criteria is that always the FE1 should be more than 70% of the predicted at the initiation of treatment. Because of this changing scenario of sublingual immunotherapy, a lot of doctors, the allergy specialists, have changed from subcutaneous to sublingual because the patient compliance is better in Indian, considering the Indian scenario. Worldwide, I know subcutaneous immunotherapy is very well used because the people know about that since ages together. But in Indian scenario, if anything happens because of the primary disease also, may not be because of the subcutaneous shots, primary disease, the patients will blame the treatment. So that's why now sublingual immunotherapy, 90% of the allergy specialists, they are using a sublingual immunotherapy in. So you can see like at a multiple levels, this allergen desensitization helps. At the specific Ig, the IgG1, IgG4 antibodies, the mucosal IgA has been improved. Then reducing the allergen specific proliferation, reducing the Th2 cytokines, improving the Th1 cytokines. So the secondary infections will be less. Then T regulatory cells, IL-10, TGF beta, they are improved. Then it improves the IL-10, IL-20, which are helpful as a anti-inflammatory and reduces the tissue and pro-inflammatory mediators like mast cells, eosinophils. They are reduced. The dendritic cell sensitivity also is reduced with that. So it has a multiple efficacy with the allergy vaccines. So these are the cases of allergy asthma where we can do the proper desensitization. And what we expect from this allergen immunotherapy, like improved efficacy over the symptomatic medication, early onset of efficacy, sustained increasing efficacy, then long-term efficacy, prevention of sensitizations, prevention of asthma, reduction uh, for the need of steroids, and cost effectiveness over the symptomatic treatment. So, which are the cases where we can do the immunotherapy? So, allergic rhinoconjunctivitis, rhinitis, asthma, large local reactions to insects, Hymenoptera, hypersensitivities, atopic dermatitis in a specific patients with the aerolesions or contact dust mite sensitivity. And depending on the sensitization is relevant for the symptoms. So the just testing is not important. Post allergy testing, the clinical correlation, the symptoms should be correlating with the sensitization also because the testing is just a sensitization. It picks up the sensitization. It does not say that the patient is allergic to those things. So again, we have to have a clinical correlation. Otherwise, what is happening? So many labs they are doing it, and the patients are confused. So they just avoid so many foods and all. It's not needed. So to rebalance this Th2 to Th1 is very important. And even the World Health Organization since 1998 has said that the targeted therapies like biologics, mast cell stabilizers, and effector cells of allergic responses and allergen contact and immunotherapy are disease modifying therapies where we can prevent the newer sensitivities and further progress of the disease. So in our center also in India, we did a biomarker studies like Th2, IL3, IL5, IL13, 33, 37, and even the ocular level. The Dr. Ushali, my spouse, she did a studies on all these interleukins and all. How they are increased into the local level also. Nowadays in USA and all, they are doing interleukin testings and mast cell basophil activation test. In India, still we don't have that, but in future it will be there, which can help for a precision medications like biologics specifically. So what are these biologics? They are a real future in most of the patients of severe asthma allergies where they require oral and parenteral steroids. We did a trials of omalizumab like around 120 patients of moderate to severe asthma about 12 years, and we found a very good results around 60 to 80% efficacy in Indian scenario. Then best of mepolizumab, bendalizumab are available in India. We are using since few years. At present, we are doing a dupilumab trial like IL-13 blocker, IL-4 blocker, where 28 patients at my center and around more than 104 patients across India, 9 centers, and worldwide around more than 1228 patients were for the moderate to severe asthma. And it has been very well used. We are using for 3 to 4 years so that the FE1, FEC reversibility can be there. So these are the future targeted therapies, even anti-TSLP. At present, we are doing a clinical trial on anti-TSLP, and so these will be the future where they can block the pathway of the manifestations and inflammatory pathways so that the patient can have a very good quality of life. Even nowadays, in skin allergies and urticaria and so many inflammatory disorders, now JAK inhibitors and all those clinical trials are also happening. They also will be future in a localized and systemic forms. So we have to differentiate the genotypes and phenotypes now. So accordingly, the interleukins can be analyzed, then what type of eosinophilic, non-eosinophilic, asthmas and all, where we can have the or these possigranulocytic or neutrophilic inflammation also. So they are rare, but most of the common is a eosinophilic allergic asthma, or some of the patients it's a non-allergic eosinophilic inflammation. So there, the patients will have a very good recovery with the omalizumab, dupilumab, or mepolizumab, bendalizumab, or future will be on the anti-TSLP and other molecules. So even patients with severe asthma, several type 2 biomarkers are seen. You can see the overlapping of the biomarkers and where the multiple parts, even where the exhaled nitric oxide is more in these patients or eosinophil cells and all, there is mepolizumab, bendalizumab, they play a very role. So now biologic therapies against the severe asthma, even the GINA 2022, they have shown that this omalizumab above 6 years, mepolizumab about 12 years. In some of the countries, about 6 years also it is used. The deslizumab is not available in India. Bendalizumab above 18 years, it is recommended. Dupilumab at present, we are having for atopic dermatitis, which is approved. For asthma and all, for the special permission only, we can have in Indian scenario. Anti-TSLP is still under trials, it is happening. So depending on that, this is a standard format where we can see the things like what are the requirements, like eosinophilic requirement or exhaled nitric oxide levels above 25 ppb. There we can use this type of, and even the good response can be analyzed with the symptoms, with the improvement in the PENO as well as the IG, and eosinophilic levels also reduce depending on the use of. Omalizumab is widely used in Indian scenario with the severe urticaria, childhood asthma, multiple food allergies, even above 1 year we are using omalizumab. I have more than 27 to 30 patient children above 1 year we are using with the multiple food allergies with the severe anaphylaxis. Their chance of anaphylaxis goes down. If they have symptoms also, the symptoms are restricted to the just GIT or skin. So the systemic symptoms like hypotension and choking and all is reduced with this type of treatment. So it reduces the inflammation, exacerbation, reduces the hospitalizations, improve the quality of life, improve the lung function, and rescue medications. So that aim is about the biologics. So there are standard charts where we can how much omalizumab can be used according to the age and total IgE level, and then the IL-5 blocker where we can use in different type of eosinophilic asthma basically. So again, the anti-IL-33, anti-ST2, etipikimab. Recently, we completed one of the asthma and COPD trial for the etipikimab, and which has a very good efficacy in around 60 to 80% of the patients. So there are some of the patients, even the combination also can be used. Suppose the patient on a omalizumab previously and he is not showing the response, then it is combination therapies like mepolizumab, bendalizumab are introduced in some patients. where they have shown a very good results. So indications, they are in a severe asthma with frequent exacerbations and signs of Th2 inflammation, and tezepelumab can be used in a, it can be without Th2 inflammation also. Then anti-TSLP, basically it is. So even the neutrophilic or IL-17 blocker also it can be used. So biologics, they work for the best for the people which are selected properly, not haphazardly, and depending on the higher eosinophilic and phenol levels. So these are the predictors for these. These biomarkers can be analyzed in these patients, and accordingly we can use it. So again, some of the patients, the success rate varies from the trials and depending on the geography of the patients. And some of the patients, if there is a like 79% of the patients continued their first biology, while 10 to percent to 11% switch to the another biology. So the most common switch was omalizumab to anti-IL-5 or subsequent switch to another anti-IL-5 or 5 receptor blocker like uh, mepolizumab. So like a 11-year-old child also, very classical case where the repeated oral steroids are used, the obesity has increased a lot. He was on multiple therapies. He took all the things. Even omalizumab was also given for 6 months, but he was not having a good quality of life. Then after the analysis and the hidden signs and all, we started on a bendalizumab, and the patient had a very good recovery. So there are studies done where people talk that the cost is very high and all, but long term wise, if you see these patients of chronic asthma allergies, they are on only medications. They will continue with the medications. They go to the complications. Again, they have a medications. In between, maybe they're having a asymptomatic period or window period where they may not have symptoms, but their underlying allergy, inflammation, newer sensitivity formation, and the further progress will continue. And one fine day that threshold will reach and the patient have severe symptoms. So these disease modifying therapies, the precision medicines and desensitization will be really useful to that. So if you talk about the annual cost also, long-term studies have been done where they have found that the allergen immunotherapy and these advanced biologic therapies and all, they reduce the annual cost over a longer period, they reduce the symptoms, improve the quality of life. And considering the rising temperatures, so much war is happening now. In Pune like city, 7 to 8 cigarette like pollution has increased, and Delhi though everybody knows about that. Mumbai also the cases is increasing only. So this increases the potency of the pollens. They travel so many kilometers, extended period of pollens also. Like previously used to have up to February. Now we are seeing up to May also. April, May, the potency has increased only. So even like this year, I will cover anaphylaxis in a few slides because the World Allergy Organization's the anaphylaxis preventable kit. So in 2006, 2003, we are having a programs in Pune about making awareness amongst the community. And we all know as a practitioners, these are the common where the anaphylaxis can be there. And these can be the early signs should be picked up by the practitioners because many of the patients, they are diagnosed as a heart attack and they are treated that way. Or taken it very casually, and still the chlorpheniramine maleate injectables or hydrocortisone, dexamethasone is given rather than adrenaline. Adrenaline is hardly given in Indian scenario initially. So as a practitioners, these early signs should be picked up amongst these patients with a history somewhere and the hidden signs of allergy or the family history, where we can pick it up early and we can be prepared to keep adrenaline injections ready. In most of our lectures, we are counseling to the physicians, to the general practitioners that always keep adrenaline ready, like whatever the Indian version, 0.5 ml, 2 syringes, next spectacle case, and keep it to the freeze till the discoloration happens. And like this was a 19-year-old dental student. She used to have a repeated cough cold and all, but once she went to some marriage and because of the photosensitivity, she had anaphylaxis. Next 2 episodes with the exercise-induced anaphylaxis. She was given so many steroids and all. IG was very high. Then one of the homeopathic doctors, she had a multiple drug allergies. She lost one child. The abortion happened because of the drug anaphylaxis. And after that, when we gave her omalizumab and desensitization, some simple precautions. So now her second pregnancy was uneventful. She tolerated the medications also. And even now, the child is around 4.5 years. This was like a significant food allergy with the inhalation of the milk. You can see like the casein in the milk. Sorry, I have some viral infection last 3 days. That's why. So casein into the milk with the inhalation level also can cause an accident. So many cases of anaphylaxis I'm seeing. The mastocytosis with anaphylaxis, wheat-induced exercise triggered anaphylaxis. There was a patient from Maldives with a significant egg sensitivity. So there are so many cases which are increasing. So we have to be prepared, treat it properly, analyze the high-risk patients, and keep it like whatever the food additives, preservatives, because in Indian scenario there is no awareness. So none of the hotels and all they have a signs. Now at least some of the five stars and all they are keeping like if you have food allergy inform us. But still the these chains of McDonald's and all they never inform. Like outside whenever we go, we see always there are instructions to the patients. If they have some allergies, inform there. So the cases, all these pseudo allergens into the medicines and foods, the sulfides added into so many barbecues and all, they are increasing a problem. So these supportive tools should be kept into the practitioners, even the receptionist and the staff should be trained on that. Because I remember when I had a lecture, one of the Cervarix vaccine was given to one of the 14-year-old girl, and she had anaphylaxis over there. When the doctor had listened my lecture and she had kept attending, the child could have been saved. So basically, these are the awareness things into the community. As a practitioners, we need a better management, at least in Indian scenario. Still, I'm finding since so many years, it's very difficult to counsel the patients and community that it is a very serious disease, it is a progressive disease, because most of the patients are happy till the rhinitis goes away or asthma goes away or food allergy. It is a natural progress. Many of the children, they overcome the milk allergy or some of the foods. So the people feel that their allergy has gone, their immunity has increased. It's not that way. Only they are in a basically dormant period or window period. Then they are going to have a severe complication. So that specific testing, the avoidance measures, the proper targeted therapies, the improved versions of advanced therapies like desensitization, biologics therapies, probiotics, and integrated and holistic approach is required into these patients. Thank you. Thanks a lot.
Thank you, Dr. Vijay, for the wonderful presentation. And I would like to now open the forum for the question answers. I would also like to invite Dr. Monica, who is into a similar field, to give her inputs about the topic. And let's open the question answers from other audience. Thank you, Dr. Monica.
Thank you, Dr. Warad. That was a fantastic presentation. You covered our entire field in like 45 minutes. I can't believe anybody can do that. And you did a fantastic job.
Thank you.
Yeah, you're welcome. One thing I wanted to ask is a condition that we look for and we screen for very commonly in the West when people present with systemic symptoms. We use the word systemic here over anaphylaxis to remind practitioners that we're looking for two system involvement because people think of anaphylaxis as a hypotensive event, which is not required for the diagnosis of having a reaction. And what we screen for here is we get a baseline tryptase level. If a baseline tryptase level is greater than 8 micrograms per liter, even if it falls within the normal range of less than 10.1, we then go forward with looking for hereditary alpha tryptosemia. So in the Western world, 3 to 6% of the population carries an extra gene that is responsible for the production of tryptase. That makes them have they're more likely to have medication reactions, much more likely to have food reactions, skin symptoms, all the systems that you had mentioned where people have symptoms. I don't know. I tried to find if there was any sort of study to understand within the Indian diaspora or within Asian populations what the prevalence of this condition is, or if there's even an approach to screen for this. For the patient who was consuming peanut butter with dust mites, like maybe 4 members of the family would have consumed that same product and not have reacted, but he did. And although you had identified that the dust mite was a trigger, what made him susceptible to having a systemic reaction? So this is kind of like one thing. And then the second thing was the use of biologic agents, and especially against, those involving eosinophilic based biologic therapies. I know that there's special permission that's required, especially what you had said for dupilumab that's known as Dupixent here. What is your understanding of the rate for helminthic and parasitic infections in patients who are suppressed from an eosinophilic standpoint? Do you see the complications from that? And I'm going to apologize. I have one third thing, and one is that for a long time we're trying to understand why there's a rise of atopic diseases. You had alluded to the atopic march, patients presenting with eczematous disorders, food allergies, environmental allergies, and proceeding to respiratory illnesses. And one of the theories, at least that's been around for a long time, is the Th1 to Th2 skewing when patients are not exposed to infections, and the Bavarian farm model, that maybe are we seeing the rise in atopic disorders in Southeast Asia because you've now adopted this very high cleanliness type lifestyle that's adopted from the West, and that you're not, stimulating your Th1 back to skewing to a more Th1 over Th2 system. So 3 questions: HAT, helminthic infections, and the third was the Th1, Th2 paradigm.
Yes, I'm absolutely, you're right. In Indian scenario, change is happening because the change of lifestyle. So specifically the rural areas, a lot of pesticide use is there. Even the grass and all, they're using the pesticides to kill that. Then the natural farm animals, they are like a anti-allergic. But in Indian scenario, what is happening? The cows are given oxytocin injections and all to have a more milk production. Then a lot of outside cows are in. So whatever the cow dung amongst the Indian cows was as an anti-allergic, but that is changing. So that's why the change is happening from Th1 to Th2. And then the cesarean born deliveries, again because of the natural vaginal flora, they used to have a Th1, but now because of this cesarean born deliveries, the Th2 inflammation increasing. And then the overuse of uh, antibiotics and painkillers during the infancy also. So that awareness is lacking into the practitioners, because in Indian scenario, what happens? Suppose the child comes with a cough, cold, and fever, nobody investigates. Directly, the antibiotics are used. So again, that is changing the bacterial flora, causing a Th2 to Th1 to Th2. So these are the things like and the changing food pattern, then food adulterations, coloring agents, preservatives. They are also causing a severe food allergies. And as I mentioned in my some of the slides, like previously we used to have a different type of Indian trees. Now a lot of other mixes have happened. So suddenly the changes are causing a potency of the pollens, and then the increase into the vehicles, sudden constructions development, that is increasing the potency of the allergens. So there are multiple factors they are causing a problem.
Thank you. And do you look for hereditary alpha tryptophanemia?
Pardon?
Do you look for tryptase levels, baseline tryptase?
Actually,
So
uh-huh.
this is all lab dependent. So this is like a condition that's come up in the last few years. It's not something that I was trained with when I was originally in allergy. But we know that at least in the Western population, 3 to 4% of the population, they have an extra gene copy of the gene that's responsible for tryptase. So these patients sit with a higher level of baseline tryptase. So they're just more likely to have drug reactions, food reactions, respiratory reactions to inhalation allergens. So is there a concept to screen
Yeah,
for this?
last 2 years it has been now provided by the laboratories, but the cost is very high. And as the patient within 7 to 2 hours, it should be ideally demonstrated. So it does not happen generally in Indian scenario. The patient they reach late, so it becomes difficult to do it. And then to monitor it also, like we should
Okay,
monitor it.
so you're talking about tryptase level that goes up with anaphylaxis and systemic reactions. What I'm talking about is your baseline serum tryptase, your BST.
Serum tryptase levels, we don't do it. We don't do it.
Yeah. So this is like something that I've just changed in my practice in the last 2 years. But I was just trying to find what the prevalence of this was in Indian scenario. And I think it's too young. It's too young. I think the price of the test has to come down. And then I think that's going to become a very important tool, because in the approach of these patients with systemic reactions is oral promolan, such an old drug. It's an old drug and it's a mast cell stabilizer. And it actually ends up treating a lot of these non-specific gut symptoms. A lot of these patients get diagnosed with IBS, and they don't have IBS. They actually have this condition. So anyway, I just wanted to share that with you. Thank you.
Good suggestion, actually. Definitely, because we are doing a clinical trials and all. So, along with National Cell Sciences Laboratory in Pune, the Pune University, I will suggest them to have for the screening for the masses, so that it should be really useful to the community. It's a good suggestion. Thank you.
Thank you, Dr. Warad. This is Dr. Chong here from Singapore. Quick question for you and Dr. Monica. Is this tryptase level related to alpha antitrypsin deficiency?
This is a different condition.
Yeah, please.
Yes.
Yeah, please, Dr. Monica, go ahead. Yeah.
So we see a lot of urticaria in Singapore, and one of the things that we actually taught long time ago is to do this alpha-1 antitrypsin protein level. And but I don't do it often because it's very hard to get hold of the test. We have to send it all the way to Mayo Clinic in the US. So what are your thoughts on doing this test, alpha-1 antitrypsin protein?
Actually, in India, we don't do that.
Okay.
Yeah.
Monica?
Yeah, so in our workup of severe asthmatics, patients who are not amenable to inhaled steroids. So in part of the high-risk asthmatic, I will get an alpha-1 antitrypsin. I will also look for ABPA. I will look for hypersensitivity pneumonitis. I might look for eosinophilic pneumonia. Yes, I actually do screen for alpha-1 antitrypsin, because we do also see a lot of asthma COPD overlap syndrome. And
Yes.
within at least in the Western population, then the prevalence of it is high enough that suggests that we can do it. And we also have companies that are marketing kits to us to say, oh, why don't you just do a salivary swab and then send it to the company? But we have it within in-house lab. So I think it's heavily marketed as well. So I think there's a lot of awareness when you have industry coming and talking to physicians. And so you get a reminder, oh, I should check alpha-1 antitrypsin, and then they do. Of all the patients, though, that come, I think it's a selection criteria of patients that get referred to an allergy clinic versus those who get to a pulmonary clinic. I think that to truly have alpha-1 antitrypsin do not end up in our clinic. They mostly end up with pulmonologists, at least in terms of the referral pattern in the West.
What about tryptase in people with urticaria? I see more urticaria than pulmonary problems.
Okay, yes. So I have quite a bit to say about urticaria. So urticaria, you have acute, you have episodic urticaria that's 6 weeks or less in duration, and you have chronic spontaneous. We don't call it chronic idiopathic anymore. That's 6 weeks or longer. We have spontaneous urticaria, and we have inducible urticaria. You have inducible urticaria from dermatographism and skin writing, from vibratory, from solar, aquagenic. Under the chronic spontaneous urticaria, 6 weeks or longer, more than like occurring every day, we do not consider chronic spontaneous urticaria as an allergic disorder. We consider it an immune dysregulation disorder. Now, you had talked about, so what I do is I get a baseline tryptase on anybody with any symptoms that don't make sense to me. So if someone has a reaction during anesthesia, somebody has multiple food allergy, I actually always get a baseline tryptase level.
Good idea.
In urticaria, it is very common to have urticaria if you have hereditary alpha tryptosemia. You can also have chronic urticaria associated with autoimmune conditions. Now, this is where allergists sit in their own kind of pod compared to the rest of the medical field, is that we do a lot of associative testing for Hashimoto's. And I will tell you, out of maybe 20 chronic spontaneous urticaria patients, even children, so pediatric and adult patients, I will find at least one new onset Hashimoto's thyroiditis that is with a TSH that's abnormal, a free T4 that's abnormal. And I have seen like autoimmune, like antithyroglobulin antibodies and TPO antibodies up in the thousands. So for patients, they don't like being told that they don't have an allergic disease because the knee-jerk reaction is, I have hives, I'm allergic to something. And I'm telling them, nope, I don't think that you have allergies, you're just autoimmune, whether it's hormonal autoimmune. I have people who've been new onset pregnancy that have hives. I have patients who are coming to me with COVID who had hives. So I just tell them that, your immune system is twitchy. Your skin is a huge, large immune organ. And at this point, I can't tell you why you have hives. The goal is to suppress it. And if we do find an associated or para-associated condition, then let's treat that as well. So, even if I find Hashimoto's and you get treated, and I send you to an endocrinologist, treatment of that underlying thyroid condition is not necessarily going to treat the hives. So that's kind of like, it's a mixed bag. Every patient is different. And even though I said chronic hives is not allergic disease, we use Xolair, which is an anti-IgE antibody, to treat it. So, but I also think that Xolair, you make IgE to viral infections. Like, I think that there's the lines are very blurred, but I still don't think that urticaria is an allergic disease, not at all.
No, thank you. Dr. Warad and Dr. Monica, thank you very much. Lovely discussion. I learned a bit myself today from everyone. So if there are no more questions from the floor, I think we've overrun our time. Are there any more questions?
I'll just quickly ask one question on the Facebook.
Yes.
And this is, I think, very common, which the patient level people are facing. So there are two questions. As we understand, there's a lot of pollution which is happening in India. So there are a lot of air purifiers which have been installed. Is that air purifier safe for allergic and asthma patients?
Yeah.
First question.
It's supportive, actually. It's supportive. Depending on at least air pollutants and all, that helps. And some of the patients with the animal dander allergies or fungal spores and all, they can be useful. Not for the dust mites. 80% of the patients have a dust mite sensitivity. The dust mites are the heavy particles, so the air purification will not be helpful. But it is a supportive.
Okay. So second question, probably the last question for the session, would be the food allergies. So there are a lot of food allergies which people are facing in this world, where whatever they're eating, like they are getting allergies. It could be a gluten allergy, it could be any kind of a grain allergy or something. So is it something which a regular people should go for testing for food allergies and get into all those things?
No, it's not needed, because practically some or the other intolerance is going to be there. So for that, the testing is not useful. So whatever the laboratories they are doing a food intolerance test, it is not useful. Actually, it is a IgG detection, and that whatever the reports positive come, that is actually a tolerance rather than the intolerance. So ideally, food allergy should be done for the patient, which has after the exposure within 3 to 4 hours, he has to show a same type of response each and every time, reproducible with a very smaller amount of food proteins. Then only the food allergy test should be done. Otherwise, it's not needed.
Okay. And I think there's a question from Dr. Rakesh Khandelwal. It says SIIT dilemma.
Actually, what's the long form of SIIT? Because I don't know.
Dr. Rakesh, would you want to come up and ask question?
Hello.
Yeah, please go ahead. Fast.
Yeah, Dr. Warad, I just wish to have one query that we talk about sublingual immunotherapy that seems quite lucrative to us like physicians. But I have a question in mind that if
SLIT, okay.
Yeah, sublingual immunotherapy I'm talking of. SL actually I was writing. Okay, so once we diagnose and we give immunotherapy, of course it is a costly and a long-term therapy. So does one single immunotherapy leads, once we have suppressed and we have raised the IgG for this, does it promotes or does it leads to uprising of a new allergen and new kind of allergy? So
No,
that means the whole exercise goes futile.
no. It never happens. Generally, it has been found that it is cross-protective. So suppose somebody's sensitivity is increasing to some of the allergens, and if the dust mite desensitization happens, the overall sensitivity also goes down, and the chances of newer development also goes down. So that's why it has been used since many years. So it's better than not to. I mean, uh, you can use it whenever. Only thing, the selection of the patient is very important. In India, what is happening is so many people are doing haphazardly and they're giving so many immunotherapies. But rather than that, the selection of the patient, the clinical correlation is very important. Suppose like a dust mite sensitivity, the patient should show the clinical symptoms in the midnight or early morning, or after going to the bed and all, or after exposure to some of the sofas and curtains or something. Such type of some history has to be there. Then otherwise the sensitivity can be there or it may not be the clinical correlation.
So I think with this note, we would like to thank our speaker for enlightening. I have a special thank for Dr. Monica Vasudev from US, and I thank Dr. Chong and everyone else, Dr. Angelique, Dr. Sanchita, Dr. Arora, Dr. Rakesh, and everyone else who has joined this session. With this note, we would like to end this specific session so that we can see you again in next session. Thank you so much.